Well, good afternoon, everyone. Can you hear me? Great. It's a pleasure to be here. Thank you for inviting me. I know that the planning committee couldn't decide or didn't want you to have to choose between sex and food. So here I am at lunch so that you didn't have to make that very difficult choice. And hopefully, you won't feel tired and need to go to sleep afterwards either. So I was asked to talk about talking to your patients about sexual health. And as I heard all the speakers this morning talking about your ever crunched time limits, but you need to ask this and this and this, you have to ask about mental health, you have to ask about abnormal bleeding, are you really going to want to also ask about sexuality? Because that really is the deer in the headlights for the clinician to say, if I open that door, talk about missing lunch, missing dinner, I'll never get out of that office. So my task is to really give you a little bit of history about sexual health for women, a little bit about function and dysfunction, and then give you some strategies to actually incorporate it into your 12 to 15-minute office visit. I have a number of disclosures, but no conflicts. These are my objectives. So let's start with this first question. Oh, it's a little high there. It really is, dear healthcare professional, please tell me what normal is. So one of the things that happens is that your patients walk into your office and they're not sure whether they have a sexual problem or not because they don't really know what's normal and what's abnormal. And so here you are, sort of the blind leading the blind, thinking, well, what is normal? Do I tell them what's normal based on statistical norms? Well, that's okay. Am I one standard deviation below or above? How often should I be having sex? How often should I be having an orgasm? Well, really, what is normal for your patients is really based on cultural norms. And historically, our culture has given very little attention to female sexual health. When we date this back to the Victorian era, at the point at which we determined that female orgasm was not necessary for conception, female sexuality essentially became demonized, and it was ignored, and it was invisible underground. I'd say under the covers, but really underground, until we fast forward to about 2014. Here we are, and really we've got Sex in the City. Primetime television talks about sexuality. We now have ads that actually say vagina on television. But really, has sexuality for women reached prime time? And I would say not quite yet. So I think in order to understand sexual function for your patients and for yourselves, it's important to think about the models we use for understanding what's normal. So briefly, let's talk about the theoretical models that are currently accepted. And there are really about 3 or 4. The first dates all the way back to the 60s with Masters and Johnson and their classic model, the sexual response cycle. Now, they were really 2 of the first to empirically study the sexual response. And when we think about, reaching prime time, now we have a Showtime series based on their research, right? Anybody seen The Masters of Sex? So they've even made that into a good soap opera. And if we remember, Virginia Johnson just passed away about a year ago. And they got it right, but they did get divorced, so maybe they didn't quite get the sexual response quite right. But based on their research, and they were able to bring men and women into the lab, so IRBs were a lot less strict back then, and they looked at the sexual response and the physiology, and based on their research, they said the sexual response really is this invariant linear progression of 4 arbitrarily defined and listed categories, beginning with excitement, which is really the sense of sexual arousal, physiologic arousal, an erection in men, vaginal lubrication and vaginal swelling in women. With enough sexual stimulation, the body reaches a peak level of sexual excitation called plateau, which then triggers what we call orgasm, which is really the culmination of sexual pleasure and the triggering of a release of all that sexual tension, and then the body moves to an unstimulated state. In the 1970s, Helen Singer Kaplan said, well, we really need to think about desire as an important concept. And so she said, really, desire's in the head, so we need a three-part model, which is desire, arousal, and orgasm. Now, Masters and Johnson did acknowledge, although they said this is an invariant model that all men and all women experience, it always goes in this order, but they acknowledged that women have an infinite variety of responses within that sexual response. So when women walk into your office and say, well, what's normal? You know, my sister says I'm supposed to have sex this many times, my friend says this, my mother's, well, maybe not my mother, my cousin says this. What's normal? Well, the fact is that there's an infinite variety of what is normal, and that's really helpful to normalize for your patients. So in this model, you can see that this could be 3 women, 3,000 women, or the same woman over a variety of time. Maybe it's the same woman over weeks, maybe it's over the course of her menstrual cycle, maybe it's over the course of pre, peri, and post-menopause. But there's an infinite variety. So woman A moves from excitement, in the pink, from excitement to plateau to orgasm. She has a multiple orgasm on this occasion, and then she drops off to resolution. Now woman B, or the same woman on a different occasion, moves to excitement to plateau, and she does an orgasm. So if this were the same woman on different occasions, guess what? That's considered normal. We don't expect women to be orgasmic 100% of the time. We wouldn't pathologize that. Even if her husband says it's a pathology, we don't pathologize that for her. But if it's the same woman on every occasion that plateaus and can't reach orgasm and she's distressed by that, then she would have a dysfunction. So you can see that even within Masters and Johnson model, there's an infinite variety of what is normal. Then we moved to the 1990s, and Rosemary Basson said, you know, these models are fine, but they don't work all that well for women, or men either, reflecting the fact that a linear progression doesn't really work for many women, particularly as we age, and that, you know, not everybody begins their sexual response from desire. You can see in the center of the cycle is spontaneous sexual drive or desire, and that may or may not be present, but that women may choose to engage in a sexual encounter for a variety of reasons, not particularly because of desire. So they may want emotional intimacy, so they would either initiate or be receptive. They may be bored, they may think it will burn a few calories, what a great way to lose some weight. There are a number of reasons why women will engage in a sexual encounter, not all of which is desire. And that desire may kick in at any point along the cycle, so it's not so linear. So in this case, many women begin from a position of what we call sexual neutrality. They're not really thinking about sex, they weren't really particularly wanting it, but you know, their partner suggests it, or cognitively they think, well, it's been a while, maybe I'll engage. And they start to engage in some sexual stimulation. Well, you know, they're kind of doing the grocery list a little bit. They're kind of going through what do I need to do tomorrow? Not really fully engaged. And if there's enough biologic, appropriate response, or no interfering biology, meaning no pain, for example, then they'll move forward. Or psychologically, things are going okay if they don't get into an argument, because that kind of shuts down the cycle. Or if there's a knock on the door, Mom, well, you know, that kind of shuts things down. But assuming all of those things are fine, as they get into sexual stimulation, then arousal kicks in. So then their body starts to respond, and for many women, that actually precedes desire. So here they were kind of sexually neutral, their body starts to kick in, and then the desire kicks in. Then it's, oh, this feels great. Why was I so hesitant? We should do this more often. Why don't I think about this more often? And that drives the cycle. And so it's important for patients coming in for you to normalize that, you know, if they've been in a long-term relationship and that sort of high passion, high drive horniness is not what drives them every time, it doesn't necessarily mean they have a pathology. If nothing ever kicks in that desire, then we're thinking about low desire. But having the order reverse so that arousal precedes desire, which is also why the DSM-5 has changed its categories. You think ICD-10 is bad, think about the confusion for DSM. But that's why it's important to normalize that for patients. And so the analogy that I would offer to use, and I would say use this slide to show how the sexual response in women works so that women aren't over-pathologized. But for many women, the analogy that works is similar to going to the gym. How many of you have already worked out today? All right, see, you're like a few of you. I hate you. But for the rest of you, you're sort of like me, and I have no biologic drive to work out. My body isn't craving it. I'm not fantasizing about when the next time I can go to the gym is. I'm just not waiting for it. So, but if I waited for that drive, I would never work out. I'd never get to the gym. So I don't rely on that. I just show up, I put my workout clothes on, I get on the treadmill. Then as I start my workout, then my heart rate starts to increase. I work up a little sweat, right? At that point in the middle of the workout, then I feel good. Then I think, oh, this is great. I'm so glad I came. I'm so glad I went to the gym. I'm coming back tomorrow. And then tomorrow will come and I'll be tired and I'll think, oh, I really want to go to the gym. And for many women, that's how sexual desire is. They don't necessarily have a lot to initiate, but once they get started, they're okay. And that's very helpful to normalize for many women. The other thing to keep in mind when you're assessing sexual function in women is that we really need to think about sexuality from a biopsychosocial perspective. It is not meant to overwhelm and think, oh, yeah, I have to cover all this. It's just keeping in mind when you're trying to figure out a complicated concept as sexual function, to think about the fact that some of the problems are related to biology, disease state, and an iatrogenic cause from drugs, endocrine problems. There are a lot of biologic factors, hormones. Then there's psychological factors. If they have a mood disorder, if they have an anxiety disorder, absolutely that might interfere with sexual function. Sociocultural factors, religious, cultural beliefs will interfere with sexual function. And of course, interpersonal factors, all of the psychological or interpersonal factors creating sort of a motivation to want to be sexual. So it's important to keep these in mind so that you can sort of tease out, what do I think is going on for this patient, and where am I thinking about my treatment? Am I referring her to a mental health professional, to a divorce attorney, or am I going to think about changing her medicines? So to be fair, there are a number of barriers that get in the way for you addressing sexual health with your patients, and I acknowledge them. I mean, I admit it. There are many problems. One is your own discomfort with talking about sex. I give the lecture to the second-year medical students about female sexual dysfunction, and when I look at them and I think, a lot of these people have, spent their lives studying. They haven't had a lot of sexual experience, and now I'm expecting them to go talk about sex. That's a lot to ask for this group. So there's the fear of embarrassing your patients. There's also a sense of, why would I talk about something that I don't have mastery about? And if I don't know a lot about sexual function, I'm going to talk about something I do know about. I know about contraception. I know about cardiovascular risk, so I don't know enough about sex to want to talk about that. There's a lack of understanding of comorbidities. By the way, nobody started my timer, so I have no idea. Oh, you're timing. Okay. So, see, it's hard to talk about sex under the watchful eye of somebody with a timer. There's a pressure. Pressure to finish on time is a really hard thing. Other issues will take priority. You've heard a whole lot of lectures that I think, well, of course those would be priorities about assessing. But when you think about what's important to your patients' lives, your own lives, sexual health is pretty important to their overall quality of life. The assumption that reimbursement is poor, I'm hoping that there are enough codes, although unlike the abnormal uterine bleeding, I didn't memorize them. Was it 696? No, I forget what it was. But there are codes for assessing sexual health. And there are no FDA-approved treatments at this point for anything other than vulvovaginal atrophy. So those are real barriers. This is another barrier. The fact is that this is a lovely Venn diagram, one of the prettiest Venn diagrams I have created, but it reflects the fact that there's a tremendous overlap of sexual problems. There's a lot of comorbidity. And so the feeling is, wow, that's too many things to try and tease out. How am I going to come to the right diagnosis? Well, it is really sort of logical that there would be comorbidity. If somebody has a desire problem, then it's probably likely that she won't have a good arousal, and she may not be able to reach orgasm, and maybe she'll be dry and have pain. So it's really about being able to quickly tease out which is the right primary diagnosis and head down a treatment path. Because we don't label just to label, we label to be able to treat. So a woman walks into your office, and a 60-year-old woman, and says, and you say, so do you have any sexual concerns? And she says, yes, I have no desire. And you think, oh, well, I just came from this lecture. I heard about, off-label testosterone treatments. She's 60 years old. She probably has, low T. Let me give her some testosterone. I'll send her off. I'm sure that'll fix her up. And 3 months later, she comes back, and you say, so, do you have any sexual concerns? And she says, I still don't have any desire. And with one more question, you find out, well, I have no desire because every time my partner and I have sex, it hurts. And it turns out she has severe vulvovaginal atrophy, and a little local estrogen or Asphena would have fixed her right up, and off she would go. So you think, oh, live and learn. So the next patient walks into your office, and she's also 60, and you say, well, do you have any sexual concerns? And she says, yes, it hurts every time I have sex. And you think, retribution, or retribution, I can finally figure out what to do for this patient. Screwed up the last one. I'm going to send her off with some, local estrogen. I'm going to fix up her VVA and send her off. And she comes back a few months later, and you say, so, how's that pain with sex? And she says, well, it still hurts. And it turns out it hurts because she has no desire, and so she never gets aroused, she doesn't lubricate, and it hurts. So not a difficult assessment, 1 to 2 questions, the second question was the key, gets you your diagnosis and gives you a much better decision for treatment. So here's the DSM-4 categories, and there are 6 sexual disorders on this list. Hypoactive sexual desire disorder is the absence or deficiency of interest and or desire for sexual activity. Aversion disorder, I won't even address because that has gone away in the DSM-5, but it really is an anxiety disorder. Arousal disorder, the inability to attain adequate lubrication and genital swelling response in the presence of desire. Orgasmic disorder, delay or absence of orgasm. Dyspareunia, pain with sexual activity. And vaginismus, which is really an anxiety disorder, which is the involuntary tightening of the vaginal muscles, making penetration impossible. So now we move to the DSM-5, which as of May of 2013 has reduced those 6 dysfunctions into 3 and has essentially combined them. There's a lot of controversy over whether the DSM-5 will hold, but essentially what's in a name, a rose is a rose by any other name. The categories are still reflective of those same symptoms. So we still have female orgasmic disorder, and now what we've done is we've combined hypoactive sexual desire with arousal disorder, primarily based on that Rosemary Basson circular model I showed you, which said it's too hard for a clinician to often be able to tease out, is it really an arousal disorder or is it a desire problem? So now it's combined, and you don't really have the pressure to figure out which one it is. You can give them female sexual interest and arousal disorder and not worry so much. So you can see the first 3 symptoms really reflect desire problems, and the other 3 symptoms are more about arousal problems. And then the third category is now made for ease of speaking, genitopelvic pain and penetration disorder, which actually you can just shorten to GPPPD, which is essentially combining dyspareunia with vaginismus, and you can see the symptomatology encompasses both. We specify as something being lifelong or acquired, generalized. Is it in every situation, or is it situational with one partner or one situation, and is it mild, moderate, or severe? So you say, well, what is the prevalence? Do I really need to worry about this in my patient population? I see mainly premenopausal women, or I see mainly postmenopausal women. How often are sexual problems really prevalent? And the fact is that based on, for example, the PRESIDE survey of over 31,000 women, from the ages of 18 to well over 65, about 43% of women reported that they had a sexual problem. Well, is that really diagnosable? Probably not. We reduced that to about 11.5% of women, and that's millions of women, probably meet the criteria for a sexual problem, and this didn't even assess pain disorders. It only looked at desire, arousal, and orgasm problems. So looking at the prevalence, we have about 10% of women, 1 in 10 of your patients, would essentially meet the criteria for having hypoactive sexual desire disorder. And that red bar reflects the fact that these are women who reported a problem and then completed a validation screener of the female sexual distress scale, which is what we use in clinical trials. And those who met the criteria for distress were in that red. So we have about 10% with low desire with distress, about 5% with arousal problems, and a little under 5% having orgasmic difficulties. So when we think about the most prevalent sexual problem, that being low desire with distress, you think, well, okay, so desire, what really is that exactly? Because it seems pretty self-evident. It's one of the only terms that my patients and I can feel like we're confident about. It's easy to spell, it's easy to pronounce. If I say desire, my patients clearly know what I'm talking about. Well, it's actually a little bit more complicated than that. And desire is really sort of a term that encompasses 3 separate but related concepts. And if you define these concepts with your patient in less than 30 seconds, it helps you differentiate which component of desire has been compromised for her, and again, gives you the treatment path. If she has a drive problem, a biologic piece, then we think about maybe a pharmacologic therapy. If it's a psychological piece or a relationship issue, then we send her for psychotherapy, right? So drive is the first component of sexual desire, and it reflects the biology of sexuality. So it is what we know of as spontaneous sexual interest. Your patients know this as feeling horny, right? How often does their body crave a sexual encounter? Not whether they're going to act on it, but how often? What's their appetite, right? They have, some of us have high drive. We want sex, several times a day. Some of us moderate once a week, some of us every leap year would be more than enough. So there's a range, right? Men on average have higher drive levels than women based on biologic neuroendocrine mechanisms, because we know testosterone, for example, is important for sexual drive. And so men on average have higher drive, but not always. But lots of things can impact drive. Like I said, disease process, medicines that they're on, and other sort of hormone and neurotransmitters. Then there's a cognitive piece, your beliefs, values, cultural prohibitions, for example, that creates interest or takes interest away, and then motivation, all of the psychological factors creating your willingness to bring your body to a sexual encounter, right? You could have all the biologic drive in the world, but if you're annoyed with your spouse, not much interest tonight, right? On the other hand, even without a lot of biologic drive, if there's other motivators to wanting to be sexual, again, burning calories, in intimacy issues, you can be motivated to be sexual. When we think about the drive components, we think about the fact that dopamine increases sexual desire, and we know that the neurotransmitters are serotonin and norepinephrine in both directions are very related, and hormones certainly modulate that as well. When we think about androgens, oftentimes we're thinking about androgens in that postmenopausal population, but really, when we think about it, testosterone, women reach their peak level of testosterone in their mid-20s, and it's downhill from there. So many of you are going to have patients coming in there in their late 30s and 40s when their testosterone levels are fading off, and they're the ones complaining of decreasing desire. It's not just at 50 when they all of a sudden walk in. And when we think about this, if you look at the decline, by the time a woman is in her 50s, her testosterone levels are half of what they were in her 20s. And as somebody mentioned earlier, even a shriveled up ovary is still producing some testosterone or still producing hormones. And so if you take out a woman's ovaries, even a postmenopausal woman, you are reducing her testosterone levels. So we know that Premenopausal women who suddenly lose their ovaries and the 50% of testosterone in their body that it's producing will very often notice that decline in sexual drive, but that's still true in a postmenopausal woman as well. So I think it's important to keep in mind, now moving on to the psychological aspects, that there are certain things that you can help sort of reinforce with your patients. And one of the things to consider is why sex is important. Well, the reality is that when we think about relationships, when sex is good, it's good. It adds about 15 to 20% of added value to a relationship, right? But when sex is bad, it is inordinately powerful, draining that relationship more like 50 to 70%. So, paradoxically, bad sex does way more to subvert an otherwise good relationship than good sex does to promote an average one, right? Think about your own lives. Most of you have probably had other relationships prior to the one you're in, and what happened to it? Initially the sex was great, couldn't get enough of each other, and it didn't really matter whether you had anything in common, whether you even liked them or not. If the sex was good, right, that was good. But after a while, it couldn't really carry over the fact that, you're a Democrat, he's a Republican, and, there are many things that sex can't sort of maintain over the long haul. But what I see in my practice is just the opposite. I see women walking into my office saying, you really have to help me because I love my partner, we're good in every other way, but if I don't fix my loss of desire, if I don't fix our sexual problems, I think we're going to get a divorce. And they are tremendously distressed by that. Everything else is good. When sex is bad, it is inordinately powerful. So I think there are some things that you can do, some really easy educational concepts that we think about as important for our own lives so we can share that with our patients. One is that once a sexual problem has become common in a woman's life, that's her identity. And even when we fix a problem, it starts to take on a life of its own. And if we don't remind her to change her own self-perception, then we're in trouble and she's in trouble. And so we fix the problem and her own sort of self-fulfilling prophecy maintains the problem. And one concept to keep in mind is self-perception theory. That is, we make attributions about our own sort of attitudes by watching our behaviors. So I know, for example, that every CME meeting there's usually a break at 3 o'clock, and there's cookies, and year after year after year, my hand goes for the chocolate chip cookie. So overall, I've discovered I like chocolate chip cookies based simply by observing my own behavior. So patients think that about their own sort of sexual identities. If I have been avoidant of sex for so long, I'm a non-sexual person. Now we give them something to treat the sexual problem. If they don't change that mindset, they're stuck. So a little reminder to change that perception is really helpful. And related to that is the second concept, which is you need to teach couples a little bit about compromise. There is often a desire discrepancy. Regardless of the genders of your couples, there's hardly ever a time when desire levels are exactly alike. And so what happens is the person who has more desire always feels slighted or rejected when the person who has less desire says, no, I'm not interested. They take it very personally. And the person who has lower desire, often your patient coming in, says, I don't know how to tell my husband. It's not that I don't ever want sex, I just don't want it as often as he does. And then it becomes a chore, it's annoying. If he's asking me every day, now it feels like, an obligation. And so whatever initial drive she had gets sort of damped down by the sense that this is annoying. And then the spouse thinks, like a good gambler, well, I'll just play the odds. If she's only interested in having sex with me, every 10th time I ask, I'll just ask every single day. You want to have sex today? You want to have sex today? You want to have sex today? Thinking I'll get lucky one of those 10 times. But that has the opposite effect because now she feels like, oh, if he would just not ask every single day, maybe once in a while my own interest would show up. So there's a discrepancy. So oftentimes, and so based on this sort of physiologic concept of too much of a good thing is not a good thing, although the spouse with higher drive would try to convince you of that, But it isn't. It's important to teach the art of compromise and to help the partners communicate about this. And the easiest way I do is to change the concept of desire and sexual drive to something related to another drive, which would be food. So back to our lunch discussion. And so I changed the concept from sex to ice cream. So how many of you like ice cream? See, more than went to the gym. I had a better hand. So now we take a couple, and I describe this scenario. So now it's it's a busy Wednesday. You get home, you fall into bed. The wife taps, let's say it's a heterosexual couple, husband on the shoulder and says, "Hey, we haven't had ice cream in a long time. Let's have some ice cream." Now he's already in bed. He's half asleep, but he's like, "Sure, ice cream. What a great spontaneous idea. I'm for it. Let's go." And they have this delicious hot fudge sundae. It's it's orgasmic. It's wonderful. And they go to bed. The very next night, just as husband is about to fall asleep, she taps him on the shoulder again and says, "Wasn't last night's ice cream great? Let's have it again." And he says, "Well, honey, I'm kind of tired. I'm not really hungry. I brushed my teeth already." And she's like, "Oh, come on. I don't want to eat it alone. Come with me." So he's a good sport. He has the ice cream with her, but it doesn't taste quite as good tonight. He's a little bit annoyed, but he doesn't say anything. Third night, same thing. The fourth night in a row, she taps him. He says, "No, I don't want ice cream. I have a headache." Yeah. So now she rolls over. She's completely hurt and rejected. He said no to ice cream. I know he likes ice cream, self-perception there. I've watched him eat ice cream. I know he likes ice cream. Why doesn't he want ice cream with me? Is he eating ice cream with somebody else and I don't know about it? He rolls over and he thinks, did I just say no to ice cream? I thought I liked ice cream. I used to like ice cream. Maybe I'm getting old. Maybe I'm getting lactose intolerant. Is it that I don't want ice cream with my wife? I don't know. So he's now trying to conjure up a reason, self-perception theory, to understand this. But what happens is he starts to avoid her. He starts to go to bed earlier or later. He doesn't want to be there to get that pressured question, do you want ice cream? And even if he had some desire for ice cream, he's not going to even bring it up because he doesn't want to get that started. And if they're driving and past Dairy Queen, they both have a panic attack. So there's something as trivial as ice cream, based on that disconnect, has created this discrepancy and now communication problems. So if you don't think that something related to sex has that big of an impact, you're wrong. And it's so much easier when you as the clinician can give a simple analogy, give them the story, tell them to compromise, and you become the hero. So based on that, let's talk about how to initiate for some basic screening for some sexual problems. So the first question is, so when are you going to do it? Here are some choices for you, but here's my simple answer. Anytime you're willing. You, me, we are no better than our patients when it comes to adherence. We learn a new skill and we try to put it into play, but if it doesn't fit too comfortably, it drops out of our repertoire. So I really don't care when, as long as you do it. And if I tell you to do it during a review of systems and that doesn't quite fit with how you run your practice, you're not going to do it. And so you'll say, well, that was nice, but I won't try it. So I'm suggesting anytime you're willing, your patients will thank you for it. So how? Do we do it as a ubiquity question, which is to normalize it for everybody? Most of my patients have sexual concerns or problems. What questions do you have? Or you could make it illness specific if you're trying to make a point. My diabetic patients or my patients after they've had a baby or my menopausal patients often have sexual concerns or problems. What concerns do you have? Not like with alcohol, right? You don't say, do you drink? You say, how much do you drink? So same thing here. You don't say, you don't have any sexual problems, do you? You say, what concerns do you have, right? So using open-ended questions certainly is ideal, and I know it sends panic throughout the room. If I ask an open-ended question, I will be there all day. The reality is we have research on this. If you ask open-ended questions, patients will respond in usually less than 60 seconds. Less than 60 seconds. The yes-no makes them annoyed. It's frustrating for both of you. It's a rapid-fire sort of yes-no 20 questions, whereas if you ask an open-ended question, you'll get the information from the patient, and they're not annoyed by it. And if you're thinking, oh, I know it's going to take forever, I know this patient, it's the same patient that would have taken forever if you'd asked her a yes-no question. So I'm saying, just try it. You know, if I'm wrong, send me an email. I'll read it for 60 seconds, but just send me an email telling me I'm wrong. But just try it a few times. Try to use language that's culturally appropriate, but also be specific about sexual terminology. And I know most of you think, I know all those terms. I use them every day. But pay attention to the fact that we get uncomfortable and your patients are watching to make sure you're comfortable enough. If you blush, if you stammer over words, they're paying attention. You need to use the terminology. You need to use fellatio, cunnilingus. Can you say it? Can it roll off the tongue? Patients are watching, and I learned this the hard way. Several years ago, I was asked to, I was interviewed for the 6 o'clock news, and it was something about a gender patient, and as I'm, giving my answer, I'm wondering, gee, I wonder if you can say the word penis on the 6 o'clock news. And so, as I'm wondering whether I could say the word, it came out of my mouth as penis. And so, it turns out you actually can say the word penis on the 6 o'clock news because that was the soundbite they used. And so the next day, I'm getting into my car, ready to drive off to work, and my neighbors wave. So, hey, Sheryl, how are those penises? And I get to work, and my patients, one by one, hi, Dr. Kingsberg, how are those penises? And so everybody could tell that I clearly was uncomfortable with that word, and they never let me forget it. So be comfortable, practice. Also, as best you can, have an open, non-defensive body posture. If you're like this saying, or worse, hand on the doorknob, you don't have any sexual concerns, do you? They get the message, they will say no, they will say nothing, and they will shut down. If you sit down, regardless of what the topic is, by the way, there is our data to show, that patients perceive you've spent more time with them simply by virtue of whether you're sitting down or standing up. So sitting down makes them perceive more time and that you cared more. Practice your terminology. I promise patients will not be offended if you use the right terminology. And the fact is that patients really will adhere to your treatments way better, not by how smart you are, but whether or not they think you have cared about them, whether you know who they are, and that you have some empathy. We know that adherence is best predicted by these factors. Okay? The other thing is we tend to try to get so much in our 15 minutes that we don't give our patients enough time to actually respond. We want to help them. But what do? We interrupt our patients. I'm sure it's only physicians and not other healthcare professionals. It's only physicians. Patients are interrupted by physicians every 12 to 23 seconds during a consultation. Right? We don't even give them, when they are talking, enough time to finish. We jump in. You want to help, I know, but give them a chance to finish what they're saying. The other thing we don't tolerate very well is silence. Right? We don't think about, we've got 15 minutes. We can't waste it with silence. But really, silence is a hugely powerful tool, not just in psychotherapy, where we have the luxury of 50 minutes, but even in your 12 to 15-minute office visit, silence would be really helpful to give patients a chance to, give a response. So, I'm sure most of you give your patients a chance to respond, right? How many of you would say that 10 seconds is a reasonable amount of time to allow your patients to respond to a difficult question? 3 of you? That's it? How about 5 seconds? Do I get 5? All right, well, let's just see what 10 seconds feels like, because I'm sure some of you are thinking, of course I give my patients 10 seconds to respond to a question. Well, I just want you to think about what 10 seconds of silence feels like and whether or not you can tolerate 10 seconds in your clinical practice. Ready? That was 10 seconds. That was interminable, right? I'm sure I could feel the anxiety building, somebody wanting to say something. So just think about how it feels in your clinical practice. It is very hard to allow that silence. Just 5 seconds would be plenty to give them a chance to respond, okay? Thinking about how you want to run a clinical practice, even not as sexual experts, think about the Plicit model. Even if all you do is the P, giving them permission to talk about sexual issues, even if you don't even want to treat it, you just want to refer them out, or giving them permission to be sexual, to acknowledge the importance of their sexual identities, is treatment enough. I'm happy. If you then go to the LI, limited information, I'd be thrilled if you gave them a little basic information. You can give them some education, show them, use a mirror, show them their genital anatomy, send them to some websites. We've got middlesexmd.com, we've got the Ishwish website, we've got ACOG, menopause.org, lots of different websites. That would be helpful. A little basic information. Specific suggestions. You don't have to spend more than a few seconds suggesting if they have difficulty with dryness, use a lubricant. Alter position if they're getting a little bit older and missionary position isn't very good anymore, or having sex in the morning instead of at night. There's no more Jay Leno to sort of signal that it's time, and next year no more David Letterman, so now what are people going to do? And then finally, intensive therapy. Not anything you need to do. You just need to know a few practitioners in your city, which you can find on various websites. The International Society for Women's Sexual Health has a list of providers. The Society for Sex Therapy and Research has providers. Send me an email. I will send you those website links. So referral out is very easy. And again, you look like the hero. The types of interventions include psychotherapy, PT, pharmacologic, alternative therapies. All I want to say about sex therapy, you don't need to know how to do it, is that it's psychotherapy, really cognitive behavior therapy, as you learned earlier, with the focus on sexual activity. So it's not about sex surrogates or whatever, your patients are panicked. What do you mean you're sending me to a sex therapist? What am I going to have to do? It is psychotherapy. Okay? It's usually brief, cognitive behavioral. Vaginismus is an ideal example of something that responds well to cognitive behavior therapy and or physical therapy. When we think about approved pharmacologic options, we have local estrogen or aspemophene for what we now call VVA, vulvovaginal atrophy, is now, go to that Vitalize website for ACOG, genitourinary syndrome of menopause, GSM. I don't know if Dr. Schifrin talked about that yesterday. And so what else do we have? We have no FDA pharmacologic approved treatments for hypoactive sexual desire disorder, the most common prevalent problem. We have some drugs, some pharmacologic options on the horizon I'm hoping for. Bremelanotide is heading into phase 3 trials. It's a melanocortin agonist. It's a very exciting, interesting PRN drug. It's an injectable. Has some good data in the phase 2 trials. We have flibanserin, which actually has now gone into FDA dispute. They've finished their phase 3 trials. Now they're working on some additional trials with, to get approval, so we're hoping for that. Librido and Libridose is an interesting idea of personalized medicine, which combines testosterone and either sildenafil or testosterone and buspirone, depending on what the presenting desire problem is. There's some treatments for arousal that are heading our way, 0 approved so far. Orgasmic disorder, cognitive behavior therapy is a wonderful treatment for that. We have no pharmacologically approved treatments, but there is a low-dose nasal gel testosterone that's in clinical trials. And dyspareunia, really what we want to do is treat the underlying condition, because it's a sort of a vague term. So think about it as multidisciplinary, and is it sort of superficial vaginal pain or vulvar pain, or is it more deep? So in conclusion, I really try to emphasize that sexual health is important to the quality of life of your patients. I would request you just ask a couple of questions with all of your patients, not at every visit, but at appropriate ones. And so I end with do ask, do tell, And I thank you for your attention. Anybody daring enough to ask a question? Open-ended, please. I think I've covered it all, either that or everybody that has that, that post-lunch lull.
No, I have a question.
Just really quickly.
Oh, yes.
In the age of the Affordable Care Act and annual exams being covered in preventive services, and then you ask them this question, which I ask all the time, and sort of opens up that can of worms, and they want everything covered in that one visit, and to encourage them to come back
Yes.
for follow-up. Any pointers?
Well, I would say that I want to validate how important sexuality is to your quality of life, and it deserves its own visit. It is often something that we can't fix in 2 minutes, and so I need for you to come back and let's spend another visit on it. And patients really are quite receptive to the idea of coming back. If it's a concern for them, they will come back. They often ask at the end of your visit anyway, right? If you haven't asked, then it's sort of the, oh, by the way, doc. So it's fine to say, great question, let's schedule a follow-up just on sexual health. And there are codes for that, I promise. If it's a menopause visit, if it's, remember, a well visit, I think, you can't sort of have a problem. So it allows them to come back, and now you've got a problem-based visit as well.
Thank you. Excellent talk.
Thank you.
Thank you very much. It was a great talk. I am privileged to work as a nurse practitioner with 2 physicians, so when I run into any problems, I can just, oh, you have to see the doctor. But in any case, I occasionally run into the women I call the virgin pregnant woman because she cannot tolerate a pelvic exam. I mean, do you have any tips on, those are the patients I give to my doctors, but
Wow.
They just...
I'm sure they love you for that. That really is the vaginismus patient. So somehow either they tolerated or did not tolerate penetration and they were motivated to get pregnant. But my very first vaginismus patient was 16 weeks pregnant when she walked into my office, and I said, well, how did this happen? And this was her second child. So that is a cognitive behavior therapist and or a pelvic floor physical therapist, refer them out so that they can then learn. It is the vagina's way of saying that, you're dumb enough to let something in, we'll protect you, and it tightens up as a reflexive responsive protection. So it is really, simplistically, a way to desensitize to wanted, which is having a wanted pelvic exam, for example, wanted penetration, and promising no pain. So it's usually, we have some dilators, that the middlesexmd.com web booth has some dilators. We use graduated dilators to teach patients no pain, and it's a parallel process with sexual activity as well. You can have sex without penetration. So, use your pelvic floor physical therapist. Asking your physicians to do it, I don't know if they're going to be thrilled with that option.
No, I just don't know how to do the pelvic exam.
You can't. You need to help them
okay. I see.
learn to relax and teach them at home using dilators to have graduated penetration, starting with this teeniest little dilator
okay.
to allow for control, and giving the patient control, by the way, which is, I know you're going to hate it, but time. To let her be in control of telling you when it's okay to start the pelvic exam, and starting with the finger first, and then gradually allowing her control.
Okay, thank you.
Yes, hi, excellent talk. Can you just address the role of testosterone supplementation in any form for these women?
Sure. Well, about 20% of all prescriptions written for testosterone are written off-label for women. So let's be clear, there are no FDA-approved testosterone treatments. For women, primarily for postmenopausal women, there is no blood test that will empirically show whether testosterone will work for them. So, we assume that most postmenopausal women are going to have lower T, but whether or not they'll respond to testosterone truly is empirical. So it is about talking to them about off-label and then using the equivalent of about 1/10 of a daily dose for men, if you're going to use one of the male versions, or essentially what has been used in clinical trials has been 300 micrograms. So you can have the pharmacist draw that up. You can teach a woman, for example, if you're going to use something like Testim, which comes in an easy-to-use tube. That's 1 day's dose for a tube would be about 10 days for a woman. So, 5 cc's or using about 1/10 of the tube. What you want is to bring her back to her premenopausal level. So you want her, no more than, 100 nanograms per deciliter in her blood levels within the normal range. But it really is empirical. And it takes up to 12 weeks to show an effect. So a woman who says, well, it's been, a month, it's been 2 months, no effect. It takes oftentimes 3 or 4 months, so she needs to give it a try. We have some data, actually the Libido-Libidose trials have shown that the CAG repeats are reflective of what women will respond to testosterone. You're not going to do that kind of genetic testing, but it is long repeats. Women don't respond well to testosterone. Short repeats, they do. Without doing it, it really is just empirical at this point. So use about 1/10 of a dose for men, use a compounding pharmacy, use a male version. It is all off-label, non-FDA approved. That was my short version of testosterone.
Dr. Kingsberg, this was a wonderful talk. I've heard many, and this was by far the best. My question is this. I've had several patients, if not more than several patients, come to me being married years and years or in a relationship, and they've never had an orgasm. I recommend self-stimulation to them. Is there something else that would help them?
Excellent question, because I think for some women it is about not knowing their bodies, and that's the first thing you need to start with. And to learn their bodies in the presence of another partner is asking a lot. So they need to know how their own bodies work alone. So even those who have sort of cultural prohibitions about that, this is a means to an end. This is really a learning process, because if they can figure out without the anxiety of a spectator how to self-stimulate, what works, what doesn't, adding in a vibrator, sending them to lovely websites to learn, the Betty Dodson websites even, which might, sort of overwhelm some people. But teaching them that masturbation is a means to an end, really helpful, and vibrators often are a nice way to sort of allow for the stimulation to override the anxiety. But there's also a group of women for whom no amount. They'll come in and they'll say, I've tried vibrators, I've tried self-stimulation, I have no anxiety about my body or sexuality, and I still can't reach orgasm. That's why we're trying some of these clinical trials for some of pharmacologic options, because I do think there may be a physiologic basis for those women who are struggling. And for them, we have to empirically try various options. Sometimes it might be some of the pharmacologic options for desire. We're trying this nasal gel testosterone to sort of trigger both peripherally and centrally some dopamine release. We just don't know yet. It's a tough question, but both ways.
Hi, I'm a medical student, so I hope this isn't too silly of a question. But I had professors, one told me that women on OCPs or hormonal contraception, so premenopausal, don't have any issues with vaginal atrophy. But I had a professor recently say that women on OCPs can actually, or with an IUD, have some atrophy and you won't see it on exam, but actually do well with estrogen. Could you just talk about that issue?
Sure. Well, when we have our International Society for Women's Sexual Health training course, which is a 3-day course, we have over an hour spent on just that topic. And there's a huge debate over whether you should use OCPs in young women, because we know that they do have, for some women, the tendency to cause problems with vaginal atrophy and low desire, by the way, as well. So it's not every woman, but you need to pay attention to, there is a subset of women for whom OCPs will cause tremendous sexual problems. So it may not be the first line when, you have to think, am I trying to prevent pregnancy, although not STIs? Are there other options we can give? And same thing for IUDs, but really it's the OCPs that are the culprit.
Sure, I was was just actually similar to her question, wondering about oral contraceptives and their long-term effect on testosterone levels, and if perhaps maybe that's why we have such a high percentage of women with these problems in the research, if there's research on that.
There is, and also the lower dose are causing more problems, and what they're also doing is raising SHBG levels, which blocks the use of free testosterone. So yes, the lower are no longer doing favorable things to testosterone levels for women, and long-term use is significantly problematic. And so when you're having that informed consent, you're not just talking about VTEs, so you now need to think about the long-term effects on sexual function as well.
Well, just a couple of comments. I'm a family nurse practitioner in a GYN office. I hear this all the time, so I had to learn some things on my own. It's sad when you have patients come to you and tell you that this is the very first time that anyone's asked them about their sexual health. I incorporate all of this into my intake with the patients. So I just wanted that to be a drive-home message, is that you need to take this back with you to your offices and make sure you incorporate it. Because I'm glad to see that there's medications actually in trials, and hope for them to come out someday soon for us to utilize in the office with these women.
It's a great point. Thank you. I'm glad you're doing that. Just to reiterate the sort of sex discrepancy, as you heard first thing this morning, there are 25 drugs approved for men for some sort of male sexual dysfunction, and other than treating genitourinary syndrome of menopause, there are 0 FDA approved for women.
This is a comment. It's been a pearl that I've used in my GYN practice that was taught to me by a nurse doula who used to work in my office. It addresses this vaginismus question, and she taught me that when you're doing an exam with a patient with vaginismus, if you let the patient know what you're going to do and you just use one digit and depress the posterior fourchette, you tell the patient, I'm going to show you the muscle where I'm pressing, and if you open your mouth like an O, it will help you to relax that muscle. And it has helped me a great deal with anxious young women and with postmenopausal atrophic women. So I just wanted to share that with people.
Thank you. Thank you.
Thank you
Thank
so
you very
much,
much.
Dr. Kingsberg. That was fabulous.
Thank you.